Hi, everyone. I know you usually expect Josh. You're stuck with me today. I'm Ellis Mayer, part of Go for Ellis, or Go for now. And today we're talking about post-professional pathways in athletic training. We're very excited. We have a special guest today, Dr. Lindsey Eberman. And we are excited for her to join. So here she is. See if she can hop on. Hi, Lynn.
Hi.
How are ya?
Good. How are you?
Good. Can you hear me okay?
Yep. Can you hear me okay?
Whoa. Yeah. I just managed to drop my phone. Um, Thanks for joining us today.
Absolutely. Absolutely. Please let me know if the beautiful Florida breeze is interfering with uh, our conversation.
No, I mean, I just wish I was there. It looks incredible.
Yes.
Um, so let's jump into it. We have a lot to cover. I'm excited to have you here. We just published your blog. So as you'll see, everybody, we're going to talk a lot about post-professional pathways in athletic training. There's all kinds of options. There's lots of different ways you can achieve your goals and your career goals. Don't worry, Lindsey wrote it all down in the form of a blog post for you. I'm brainstorming visual aids because I think it's a little bit complex. So we will try to help answer any questions that you have. If you do have questions, feel free to drop them in the chat. First, let me introduce Dr. Eberman. So Dr. Lindsey Eberman is a professor and the program director for the post-professional doctorate in athletic training at Indiana State University. She first earned her bachelor's degree from Northeastern University in Boston, Massachusetts, and her post-professional master's in athletic training and her doctorate in curriculum and instruction from Florida International in Miami. Dr. Eberman has been acknowledged with several awards, recognizing her commitment to teaching, scholarship, and service to the profession at the local, state, regional, and national levels. She facilitates doctoral student scholarship that improves the practice of athletic training and maintains a robust research agenda of her own, amassing over 350 published manuscripts and abstracts. Lindsey, that's amazing. She currently resides in Terre Haute, Indiana, obviously not there since it's blue skies and there are palm trees behind you. She sees her most important role as an aunt to 3 nieces and a nephew. She enjoys cooking and baking, reading, exercising, and socializing with friends and family. Thank you again for joining us today.
Thank you so much for having me. For those watching, I definitely told Ellis she shouldn't read the snooty background, but I was overruled in my decision there. I'm fairly certain we saw a question already. I'm fairly certain that is not a background. Ellis, is that your real life your foliage in the background?
This is
Or
my
is
real
that
life background. This is
yes,
what happens when you work from home in COVID. You amass lots of
exactly.
plants.
I
So,
do know Ellis has the best home garden I've ever seen, inside and outside. So
well, when you're locked up in a city, you got to figure out something to do over the last 2 years.
exactly.
All right,
I
so
just
let's
have
get
like a measly 5 plants, but it was my growth during that period. Yes.
all right, let's jump in. So, um, I've just graduated. I've got my master's in athletic training. What are my options as a new grad? There's a lot of different terms out there, and I just want to kind of go over like what should I be thinking about, and what steps in different areas can I take to get there?
Ellis, I think that's a really good question, and I'm gonna just suggest that we take a tiny step back and consider, who do I go to for this advice? Obviously, you can come to an IG live and we can have a conversation, and I'm happy to share my broad expertise in the post-professional space. But we know that students who are going out into graduation, they're asking their preceptors, they're asking their faculty. And this is where I think it's a responsibility of preceptors and faculty to actually expose themselves to the environment. With the degree transition, the post-professional pathways are fundamentally different than our experiences. I did a traditional post-professional master's degree, which the intention there was for me to transition to practice and get clinical experience. Yes, I was really lucky. I went to a place that focused on advancing my clinical practice skills in addition to my transition to practice. But as we move into this professional master's space, those post-professional transition of practice experiences are going away. And so when we go and ask our preceptors or our mentors, what do I do? They're telling us what their experiences were. And we shouldn't really be following down that path with such a drastic change in how we're educating folks. We need to know what all of our options are, know what our priorities and values and what drives us. And that's what's going to help us make the right choice in terms of a pathway. So before I get into all of them, I think that's really a critical piece. Like, when I go to ask somebody for advice, they're not being disingenuous with you either. They're telling you what their path was, but things are just so different than when some of our more experienced, I was going to say older because I am older, but some of the more experienced folks, that pathway is just not there anymore. And so I have a responsibility as a mentor to know what to do in the space and to really listen to my students when they're saying, these are my goals. If somebody's saying, I want to be a specialist, I want to be the person who comes, I'm the person people go to when there's a difficult case in the room, then I can answer that question. I can help you find a pathway. But we got to be listening to what's most important. And it's not always the ways in which we've always done it, which I think for you and I, we have these conversations all the time, but the way in which we've always done it isn't always the best way. I think we know that's true.
Yeah, absolutely. So we have to establish what do we want to do? There's so many different options in athletic training. What you do as an athletic trainer is what different than what I do as an athletic trainer. There's so many different settings that we work in, and with so many different areas that we really excel in. So it's really, you have to figure out what you kind of, your end goal is before you kind of take that next step.
Yeah, absolutely. And I think there's often been a stigma associated with not going on to formal education. Like, there's so much value in continuing professional development if you're using good resources to guide that. So if you're using quality improvement data or patient care data that's coming to you in your practice that's saying, hey, I might not actually know what I'm doing here with this lateral ankle sprain, which I make a lot of assumptions about, right? So there's really good data we can be collecting in practice that can drive continuing professional development. And that is one pathway. And I didn't talk about it much in my blog, but I want to hammer this home. Continuing professional development is the most important critical responsibility you have as a healthcare provider. And all of us should be doing it, whether we choose formal post-professional pathways or not. We should be engaged in professional development in a way that makes us lifelong learners using data to drive our decisions in how we learn and develop more. So continuing professional development is absolutely an option. That means go out and get a job and learn about yourself as a provider, and then use the information that you're gathering. And I would really suggest this is where you combine, I know I'm going to use fancy research terms that scare the crap out of people, but they're intentional. We need both qualitative data, that gut feeling that we have, I'm not good at this, or I didn't do this well, but we also need some quantitative data. So those patient-rated outcome measures, patient satisfaction data, injury rates, return to play, timeframes, making sure you're within norms. Those are all good ways to say, I'm on par with peers, or wow, this is an area that I need to really hone in on some evidence-based practice and some literature to really step myself up. So I think one pathway to talk about is continuing professional development and doing it in a really intentional way. From a more formal perspective, we still have those masters and the post-professional masters. And we're seeing folks continue to use those pathways, although we are seeing enrollment finally dipping in that space. We actually think we were expecting to see that dip a little bit earlier, but we're now actually seeing some enrollment in some of those programs that maintained accreditation or maintained their post-professional master's programs, and they are now seeing those declines in enrollment. But they were primarily focused on transition to practice and advancing clinical practice skills. So giving you a space that was mentored, hopefully safe to practice, where you were getting good advice from mentors, you had people to consult with on cases. And so the intention there was for you to kind of ease into your clinical philosophy, the person you want to be as a provider. But it also gave you structured formal education to kind of level up. It gave you some more, maybe some more credentials or some more some more specialty certifications or certifications. I don't want to call them specialty certs, but additional certifications that might have expanded mostly in the skill space, the clinical skill space, versus some, although different programs chose different paths, instead of kind of large, big picture things, they might have focused on kind of practice skills. Some of those accredited post-professional programs did have that bigger picture, that core competencies that we're now seeing integrated into the professional programs. And these were built by the National Academy of Medicine and really embrace like whole person healthcare. So patient-centered care, health information technology. So less about the actual clinical skills and more those clinical philosophies that help drive who you are as a provider. So as I said, though, that pathway, it still exists, and there's several programs out there. And I would have to say, the easiest way to find them is through graduate assistantships on the NATA Career Center. There is no central house location for a lot of these post-professional formal programs. The Katie does have a searchable space for accredited post-professional programs, and you'll see a blend of both doctoral and post-professional master's degrees in that space or in that area. But the NATA doesn't post a list of potential programs either. And so I do think there's some disadvantage to the consumer in terms of finding what programs are still available, who's still recruiting. And so the NATA Career Center is helpful in that if they do have a graduate assistantship associated with their programs. Then there's we've got the residency and fellowship space. And I think this is a place where we've got lots of confusion in our professions, yes. Right? So residencies and so I'm going to start with residency.
Well, can we also talk about internships too? Like, yes, I feel like
yes.
the three of those are used interchangeably, and I want to split the residency piece into a residency and an accredited residency, because I think that they're also billed the same way, and there can be a confusion there too.
Yeah, absolutely. So let's start with internships. Internships, again, place you can find them would be likely on things like CATS listserv, because almost all internships are located in college university setting, or the NATA Career Center. And I know that there are going to be people out here that believe this is an unpopular opinion, but I am 100% okay with my unpopular opinion. Internships are not only harmful to the learner, they are harmful to our profession. They are creating a space where somebody can pay you an inappropriate amount of money to do an inappropriate amount of work without the formal education and mentorship that's expected of an internship. The federal government actually has a definition of internship, and learning is required. So if you are standing there holding a water bottle for 80 hours a week and you're telling me you're learning something, I am very disappointed in whatever learning you think is happening.
So how do you avoid that situation? Like, what is your advice for vetting an internship?
Well, I would suggest don't take them.
Just don't even go there.
But if you do choose to go there, it's asking what kind of mentorship is going to be available. What is the supervision plan? How much am I expected to work? How much of that is autonomous? How much of that is going to be with an experienced professional? What does experienced professional mean to you? Because if you're telling me I have a grad assistant supervising an intern, I'm not sure that would qualify as a mentored clinical relationship. What's the experience of the person that's going to be mentoring me? Do they have a specialty certification? Have they been trained in a residency? Do they have post-professional education? What are their credentials? Am I going to be doing all of that work independently? Where am I going to be doing that work? How am I going to be compensated? And what are my protections and parameters for which, if I ever feel exploited, how do I resolve that problem? So if I am being exploited as a clinician, what's the mechanism to report that? Is it human resources? The answer is yes. But it also could be the federal government. If it's a federally funded institution and they're engaged in calling it an internship, there is potential for ramifications there as well.
I think this is also a good scenario where everybody will learn this quickly, that athletic training, the world is whatever, we're all 6 degrees of separation from each other. The athletic training is like 1 or 2. So I think using your existing mentors, your existing preceptors, your existing network classmates, if they know anybody that's gone through that program or worked there, and ask them about their experience. Or even if that particular program could have you speak to an intern that just went through the program and ask them about their experience. I think that's a really good way to try and ask what it's like to actually be there.
I also think some of the professional sports societies have really tried to remove the stigma associated with internships by providing more perks and benefits, right? The access to high quality continuing professional development, the mentored experiences, using different time structures to teach kind of different parts of the job in some of the professional sports settings. I do think that that has improved and has created some hope in that internship space. But I do think for the large majority, we are seeing exploitation in the internship space. I think what we're seeing, particularly as a result of the pandemic, is that folks are leaving their professional programs feeling like they don't have enough clinical experience. And that's not a reality of the ideal curriculum that our programs have curated. It's a function of not being able to send our students out to do those experiences in the way we had intended and having to modify to do those things. So I do think it's really interesting that we did see in 2021 a really hefty group of folks willing to do an internship because some of their clinical experiences were rather limited because of the pandemic. I'm hoping now that that's not the case, that the healthcare system has adopted athletic trainers as an integral part of what we do in healthcare, is helping prevent things like transmission of COVID. So I'm hopeful that people didn't lose out on clinical experiences quite as much, but we are going to see another class of folks that were at minimum impacted by their last year as an undergraduate student or their last year as a high school student. Their time in undergraduate education that may impact their overall experience. And I think what it did was decrease self-confidence and self-efficacy. And so the choice to do an internship was a lot of like, well, I don't want to embarrass myself in a real job. And I totally appreciate that. But at the same time, taking those positions really puts, again, the profession and you in a position where you could be harmed. And so you got to, if you're going to choose an internship, my suggestion is think of the most cumbersome assignment you ever had as a student in terms of how much work you had to put in to really research and investigate whether something was the right thing for you. That's the amount of time and effort you should be putting into whether you should take an internship or not. It shouldn't just be I interviewed and got a job and, oh, wow, they like me and I like them, so let's go for it. That's called online dating and doesn't turn out so great, right? And it may for some folks sometimes, but we also know the numbers are not in our favor, right? It's more about thinking about how diligent you have to be, because that can set you up long term for hating the profession and leaving. Like, that's the thing I don't want, is people taking those jobs and then saying, wow, the profession isn't for me because of that one bad
setting. Yep.
Yeah.
Absolutely. I absolutely agree with that. You can have a bad experience one place and say, this is not what I want. And you've got to understand that it's not like that everywhere. If you do, there are places where it's a great place to be.
Yeah, absolutely.
Okay. So we've kind of talked about internships. The natural progression, do you think fellowships? We're going to talk about residencies and non-accredited residencies and accredited residencies.
Yeah. So, again, strict, hard and fast rules by Lindsey. Non-accredited residencies, I think there's some, I like to call it masquerading. It's an internship masqueraded with a different title. And we see people using the title of resident or fellow in former internships because they're smart. They're working the market too. We are all collectively saying the term intern or internship is not good for our profession. So instead of adapting the job to a full-time position or getting themselves together and offering an accredited residency, they're using the term residency and fellowship, and they don't have the didactic and mentored components that are part of accreditation. So the accreditation standards are really specific in terms of how much time is spent in the focused area of practice and how much of that time needs to be mentored. And they're also focused on how much time in the didactic content. So most of our accredited residencies are in the orthopedic space. So I'm going to use that as an example, but I hope there's somebody on this call dying to put another primary care residency on the map, or helping us to find the first prevention residency, because we really need those residencies in the near future. But so most of the stuff, or most of the residencies, are in the orthopedic space. So when we look at unaccredited residencies and fellowships, often the employer is unable to say where the focus area of practice is. So they'll say things like men's ice hockey. Well, that's great. That's a sport and a specific setting. But unless you are breaking down the number and type of orthopedic injuries that can help me understand where I'm going to develop an area of expertise or a focus area of practice, then to me, those are folks that are really struggling to offer what would be potentially an accredited residency or fellowship. So you should be looking for some specific language about focus area of practice or specialty area, and you should be looking for how much time is focused in that practice. So just as an example, we do have residencies in college university settings. There's one that primarily functions in college athletics, recreational athletes, and ROTC. And they're able to actually identify how much time is spent in orthopedics by way of sport assignment or patient panel assignment. So when they're working in that space, we know that they're seeing a majority of those patients are in orthopedics, or a majority of those patients are in neurotrauma and spine. Where in some of these other residencies and fellowships, you're just assigned one sport. And that's where the problems arise, because we all know that as much as college athletics has become a year-round activity, we know that there is an ebb and flow of a traditional sports season. So if you have one patient panel and that's the only patient panel you're working with, then you will be focused on the common experiences of that patient panel, which for some folks might not be orthopedics. Like if I was working with wrestling, it's more likely I might be doing primary care than orthopedics based on the sport assignment and the more common things that are happening with that patient population. So the folks that are offering the job should be really able to say, this is how I know that your patient panels are getting you better in orthopedics or in rehabilitation or in prevention. And then those that are using fellowships, like we don't have an accredited fellowship yet in our profession, but that's where you're developing subspecialty. So if anyone is out there telling you that they're offering a fellowship, they should be able to speak to how they're not just taking you past specialty area like orthopedics, but how they're taking you into pediatric orthopedics or taking you the step further into a subspecialty area. And so that's, I think, one of the key questions, but it still goes back to some of the same things said about internships. Like, you should be expecting mentored experiences. You should be expecting an experienced mentor who has also demonstrated themselves to be a specialist. And you should be expecting complementary didactic instruction as a function of any residency and fellowship. And who am I to say that somebody is not doing that in an unaccredited space? It is definitely possible. And if you are facilitating one of those programs, I ask you to reach out to me or reach out to Holly Wallace, because we want to help those programs become accredited. The Katie wants more residencies and fellowships. And so if you're doing all the right things, get yourself accredited and make yourself marketable, because those programs are in a space that the profession is going to embrace because of that quality assurance that's part of accreditation.
So how many currently accredited residents? Oh, hey.
lost you there. Sorry.
We've all dropped we've at least dropped each other once today.
Exactly.
So how many accredited residencies are there right now?
Oh, you tested my knowledge. It's around 10-ish, 10 to 12. And we're seeing more programs applying. We are also facilitating a lot of emerging residency and fellowship programs through the Katie Education Committee, which is I currently chair. So we collaborate with the commission in general, as well as the residency and fellowship committee, to try to provide programming to help emerging programs get accredited. And so we did a workshop last summer, and you should expect to see another workshop this summer. We really want folks who are doing all the right things in their residency and fellowship space to seek accreditation. And I would have to say, in all my years of education and all my years associated with accreditation, I have never seen a more collaborative and constructive group that's working to help people become accredited. So I really do encourage folks to reach out and just ask questions, because we really want to help those programs be successful and become accredited.
That's awesome. That's a great resource, and thank you for helping everybody, because we all know accreditation process. I've never been through it, but I've witnessed several friends who have gone through it, and it is a lot of work. So that's a service that we need, and the collaboration that we need. So let's talk a little bit about the BOC's orthopedic specialization certification. So what's up with that? How is that different? What does that get you? How does that impact your career goals?
So we don't actually know what it gets you yet, right? Because these kinds of things come into the space, and then we can only have aspirations of what it's going to offer us. So in almost every other healthcare profession, and certainly our peer allied healthcare professions, there is a form of specialization. And so this is just us aligning with other folks in medicine and other rehabilitation sciences.
So can you give us an example of that so it easily translates in everyone's brain?
Sure. There's an orthopedic specialty certification in PT. It's the perfect comparator. Somebody does their professional education, and then they go and do a residency. First, when PT started, they had the opportunity that you could not do a residency, and so you could do it based on experience. And then over time, and I am not 100%, but over time they at least want to or have eliminated the option of doing it, of sitting for the specialty certification exam without having done a residency. I know folks who have gone either path, where they took the exam based on experience or they did a residency. So I know that it certainly was not a like overnight, we're going to eliminate path, for the way that BOC is describing it as path 2, which is your experience path. So but there are definitely, even if you think about medicine, right, a specialty is orthopedics. You think about athletic training, specialty orthopedics. You think about physical therapy, specialty orthopedics, right? So all parallels. So in terms of aspirations, what we're hoping it will do for folks, it will help you in the employment space show that you have knowledge, skills, and abilities that maybe that exceed traditional competence or traditional competence in the profession. And it will, if I were an employer, the ideal workspace, and I'm trying to curate the ideal group of employees, I want a bunch of advanced generalists, so people who have range and breadth of knowledge, skills, and abilities. And then I want a few folks who have this specialization where they can help with rare cases. I can refer a patient out of my panel into their panel, and it's not about you work men's basketball and only you see men's basketball patients. Like, what harm we're doing to patients when we're saying this is my patient? We really need to forfeit our ego in that space and encourage folks to seek care from a specialist if it's a more complex case, that the patient's not improving, or it has complex features, there's concomitant characteristics of the case. That's where you want to bring in a specialist who can handle more of those rare and complex cases. And again, fellowships even further down the path, folks with subspecialty, like a pediatric orthopedics case or a neurotrauma specific case. But there are two paths to that specialty certification, the first being a formal residency. And so the expectation from the BOC is that you have 1 year of employment and 1 year of the residency, and a total of 2 years of experience And that has to be an accredited residency. And the BOC website is actually really specific about eligibility criteria and lists all the current accredited residencies that are eligible for that particular specialty certification. Path 2 is at least 260 hours of continuing professional development and 3,500 hours in the focus area of practice or inside orthopedics. And 1,200 of those hours have to be mentored by a specialist, and 1,000 of those hours need to be in the preceding year. So for instance, for me, I've been not necessarily clinically practicing in the last several years, but I certainly have 260 hours of continuing professional development. So if I decided I wanted a career shift and I wanted to have a specialty certification, I would need to go back to practice and put in 3,500 hours, and I need to be able to demonstrate that those hours are in orthopedics. So I would do that by demonstrating how many clinical exams I'm doing in the orthopedic space. I would then work with a mentored provider. So I would think, my example, I worked in secondary school athletic training. I would want to make sure that my overseeing physician is mentoring my practice for 1,200 hours. And that might be chart auditing and taking a look at how I'm approaching clinical exam, regular consultation, grand rounds and discussing patient cases, making sure that we are doing critical case reviews when I have a negative outcome. That would be the kind of mentorship I would expect in that space. And then obviously 1,000 of those hours in the preceding year, meaning I need to be spending 1,000 hours in the next year, which if I were to structure this for myself, it probably would take 2 years of practice if I were to start today. So when we go back to the original question you asked, which was, I just graduated with my master's degree and what do I do? That second path is not achievable for a little while. And I do think the residency is the most efficient path because that structured mentored experience is there and a didactic continuing professional development is there. So that is one option. Now, again, for unpopular opinions, I do think it was an error on the part of the BOC to expect one additional year of employment because a residency is a residency. It's that structured, focused experience. They're allowed to engage you in your residency work up to 80 hours a week. So the idea that 1 year of a focused residency isn't sufficient to sit for the exam, I personally disagree with that. But that's the choice the BOC made, and this is the choice we live with. So that's where we are.
Okay, so I feel like we've covered our first level or several levels of post-professional education and your choices and your pathways. Let's kind of rise up to the doctoral level and PhD, EDD, DAT. Let's start with our EDD and then kind of go from there to PhD, and we'll end on the DAT. How's that sound?
That's great.
Okay, so I think who is the person that goes and EDD? Like, what are my career goals, and how do I get there? And go ahead.
I think, yeah. So great question. I do think that in higher education, there is often an interchangeability between PhD and EDD depending on the institution. So for instance, I went to a Florida International University at the time. They had an EDD in curriculum instruction and a PhD in curriculum instruction. So because I had a higher focus on research and educational research, I chose the PhD, where folks that might be principals in K through 12 education were pursuing an EDD. And so that would be considered a clinical practice or an advanced practice degree for an educator. So if we're thinking about those with an EDD in athletic training, these might be the folks that are engaged in the practice of teaching. So program administrators might be really well positioned to engage in an EDD. I would say from a historical perspective, that's not accurate, right? So we have people with PhDs who are highly specialized in ankle research, serving as a program director, and nobody trained them to be a program director. And that's not to say they aren't really good at it, because I've met lots of people really good at program directorship, but their research area was totally different. I just know for me, the educational content I received, and in the program that we facilitate at ISU, our PhD is in curriculum instruction. Those folks are being trained on instructional design, curriculum development. They're being mentored in accreditation. So they're really well equipped to be in the program administrator position because of that training in curriculum and instruction. And that's where you're seeing most of the EDDs in the educational research, the educational psychology space, educational research space, educational leadership space, and curriculum and instruction is where you're going to see a lot of those EDDs. And so those folks might be really well positioned for program administration. They might be great at doing things like being your simulation facilitator for your program because they might have experience in media technology or healthcare simulation. And so I think if you're saying to yourself right after a master's degree, I really want to be an educator, I love you already and I don't even know you. But I do think the one thing I have definitely learned, and whether it's graduate assistantship experience, transition to practice experience, we do need clinical experience in the class, in the clinical setting to be effective in the classroom. And so thinking about continuing professional development or a transition of practice experience like a post-professional master's degree is pretty critical to being most effective in the classroom. Just think about trying to explain to somebody, like right now I'm working with my mom, she just got a total knee replacement, and how difficult it would be for me to explain things without examples. So using commonplace examples to help her understand how to manage her pain or how to manage her post-op care. Think about trying to be in a classroom and giving examples of clinical exam, and the only examples you're able to draw from are not autonomous. And I think that where you maybe weren't the primary decision maker, and I think that's, in my experience, it's put some people at a disadvantage in the classroom. So for those of you seeking to be a PhD in EDD, for sure, getting some clinical experience under your belt, because that's what's going to make you most effective in the classroom.
From a hiring standpoint, what is the difference? So are most universities looking for somebody with an EDD? Are they looking for a PhD? Like, does it put you at a disadvantage in some universities to not have a PhD if you're applying to to be a program director at an R1 institution? I feel like everybody always says that a PhD is the creme de la creme. That's what you should really be aiming for. Is that necessarily true from a hiring standpoint?
The creme de la creme is what you want out of your job, your life. So whoever is telling you the creme de la creme is something that you don't want, stop listening to them and reassess, right? The creme de la creme is, what are my values? What's important to me? What is my career trajectory? Which, by the way, you can change. Permission granted, right here, right now, permission granted. You can change your career path. But you got to look deep inside yourself to know what you want. So if you're saying, oh, I really want to be an educator, but gosh, research sucks, don't go pursuing a PhD. It will be a painful experience for you. It will be a painful experience for your mentor. Give yourself the joy of not doing a PhD if it doesn't fit you. The PhD is considered a terminal degree in terms of a research credential. So when I got a PhD, somebody could say, Lindsey, you can do autonomous research. You can do research by yourself and you don't need a babysitter. I probably need a babysitter for other reasons, but I don't need it in the research department. So yes, a PhD, if you want to be a researcher in an R1 institution, then a PhD is what you need. I don't want to use the word specialization, but that is the word that we often use in higher ed, and it gets so confused with residency fellowship, so I don't want to be misunderstood. But your focus is super narrowed into a particular thing, I would consider, hopefully, a clinically meaningful problem. And you have a research agenda that's focused on resolving that clinically meaningful problem. And so you build project by project, brick by brick, a path toward resolution. And so that's what a PhD is going to give to you. For me, I was lucky because I got to blend a curriculum and instruction PhD, and I love educational research, right? So I get to do that hyper specialized, hyper focused research, but I also got the complement of how to run a program as part of that degree. So to me, a PhD in curriculum instruction is the perfect marrying of a PhD and an EDD into a happy little educational frenzy that I obviously am very clearly passionate about. But the PhD is focused on research. So if you want to be a researcher, you're going to have to put some time in, both chronologically and intellectually, into a clinical problem and pursue it in that way. Traditionally, people get a master's degree before they pursue a terminal degree like a PhD or an EDD. And that's going to be a little shaky for us for a little while, trying to figure out how that works, right? Because what I was saying to you earlier is you need clinical experience to be effective in the classroom. But somebody who graduates from a professional master's program is academically eligible for a PhD or an EDD or even a DAT.
Yep.
So I think it's about giving yourself the time and space to be really successful in that terminal degree as EDD, PhD. And I'm going to shift gears really quick, but the DAT is also a terminal degree. It's an advanced practice terminal degree. And there's been some, hoopla on the AT Twitter about whether a DAT is a terminal degree or not. And I will stand here, hand to heart, that 63% of department chairs several years ago, 2015, which I would consider at the front end of DATs, at the front end of this intellectual shift. And those folks were saying we absolutely would hire somebody with a DAT. So saying that there's not space for a DAT in a faculty position is just not authentic. And it's also a terminal degree that's focused on practice. So I am saying, yes, it functions in education. That's not necessarily its purpose. If you look at all the DATs around, they are focused on advanced clinical practice skills and advanced practice leadership. So even though each of the programs has range in terms of what its kind of programmatic focus is, it's also the core tenets, whether we agreed on it or not when we started, was we're seeing focus on advancing clinical practice skills, and we're seeing focus on advanced practice leadership in each of the programs. And obviously each of the programs are doing those things differently, and some are more successful than others. And then the other piece that's really great is that the Katie has decided not to continue accreditation, but what that gives us is market variability. So if somebody wants to be an entrepreneur, there's a space for them. If somebody wants to focus on practice advancement and advocacy, there's a space for them. If somebody wants to focus on leadership, or a hyper focus on leadership or personal and professional development, there's a space for them. So if you're a consumer looking for a DAT, if you're coming straight out of a master's degree, there's only a handful of programs willing to, well, I guess that's not true anymore. So if we're talking about folks coming out with a master's degree, you should be eligible for any of the programs, because right now nobody is requiring practice experience, although it is recommended by some of the programs. If you are coming out of a bachelor's degree, there's only a handful of programs where you'd be eligible to go straight into a doctoral degree. But for those coming out of a professional master's program, you would be eligible for many of the doctoral degree programs. Some pros to that: folks want to get their feet wet. They see themselves in practice leadership. They're excited, ambitious. They also like formal education. Then a DAT is a good space for that. Each of the programs varies in total number of credits, total cost, and I think the job as a consumer is to really compare your professional goals and what the programs have to offer. Because I think that we're having such a huge debate in America about cost of college education. And I totally appreciate that, but I absolutely see the DAT as an opportunity cost. What is lost by choosing not to go down the path of a DAT? How much long-term earnings can you lose by not choosing the DAT, and when? How much quality of life? Because I think specifically our DAT focuses a lot on how do you find workplace satisfaction and agency in our profession. We have so many athletic trainers feeling pushed around by the system and pushed around by athletics, the sport industrial complex, and now feeling pushed around by healthcare, more so as we're trying to see ourselves very clearly as healthcare providers. But I know in our program, like, our job is to teach folks how to navigate that system without quitting our profession, because I think that is unfortunately happening way too often. Is some of these post-professional pathways are putting people in really vulnerable positions to be kind of manipulated by the world that they work in. And so finding folks that are trying to help you, empower you to because you have the power, right? You have that power yourself. It's about teaching folks how to harness that power and leverage that power so that they have job satisfaction, workplace satisfaction, and that they know how to set personal and professional boundaries to not feel like the system is always pushing them around, but that they're in charge of their own space.
That's awesome. How many DAT programs, I know we kind of talked about residencies, how many DAT programs exist out there?
You're catching me on the numbers.
Sorry, I should have prepped
It's okay. It's about 7 to 8. I think we're seeing proliferation of programs 8 and 9 in the next couple years.
But again, you said that Katie got rid of the accreditation piece of it, so we're
currently the only accredited program. And what we did was we elevated our post-professional master's degree. So just like a lot of the professional bachelor's degrees, they were able to submit a substantive change. And frankly, our institution, under the leadership of our provost, who was exceptional, allowed us to expand our curriculum from 36 credits to 57, allowed us to use a cohort model that has served us incredibly well, that allowed us to think different about how to educate people, because we were able to do focused intensive learning experiences for students that were incredibly meaningful. And if you ask any of our alum, they're saying that was the most critical time for me, because we're also allowed to do things like simulation, which a lot of the other programs aren't doing. It gave us an opportunity to assess and appraise how much students had advanced as clinicians, because I think that's the difference between our program and some of the other programs in the DAT space, are that they are saying, I'm giving you advanced practice clinical skills, but there's no function for them to measure it because they're not in the physical space and evaluating that. And so I think that has really given us an advantage. So we are currently the only accredited program. That accreditation will end in 2026, and that's just because of what the Katie has chosen to do. We're trying to embrace it as an opportunity for more expansion. We try not to expand in terms of number of credits because we know how important that cost of education is to students, but we are using it as an opportunity to think different about how to we have to continue to evolve. And so we're expanding in terms of inclusive healthcare. We'll be offering new courses in that space in the next year, and really a high focus on quality improvement with the BOC's shift to continuing professional development to include that quality improvement component. We really looked at our curriculum and said, where can we do this better and more explicitly? Because we're doing it, but it wasn't public. And we know how important sometimes making our curriculum a vehicle for marketing and drawing students in so that they can see how what benefit they're going to get from the program.
Well, thank you, Lindsey. This was awesome. It went by really quick. We're already at like 50 minutes, but thank you everybody for tuning in. If you're thoroughly confused, don't worry. Like I said, we wrote it all down. We're going to work through some flashcard flowchart ideas with Lindsey, because I feel like there's so many different pathways. There's so much information here. But like Lindsey said, feel free to reach out to me. We can also get you involved with Lindsey, and she can kind of help you talk about your goals and how to get there too. Thank you again for joining us today. And this was awesome. Enjoy Florida. I'm jealous.
Yes. Yeah. Hopefully I'll get a little bit of sunshine, but mostly it's just taking care of mom. This is what happens when we all get old.
Well, and we all become our athletic trainers for our parents.
Exactly.
All right. Thanks, Lindsey. Have a great day.
Bye. Take care.
Bye.